Yep, you're all getting connected. Happy Wednesday, everyone. I'm so happy to see all of you today. Glad to have you joining us. My name is Anissa Mitchell with PMD Alliance. And with us today is Allison Lindauer, who is a nurse practitioner, PhD, nationally certified gerontologist, nurse practitioner who does research on dementia caregiving and telehealth. And today we're going to be talking about coping with behavior in dementia. Before we get started, I want to invite you to open up your chat box and give us a shout out. Let us know where you're joining us from. We love to connect with you. We like seeing your faces, but it's nice to put a name and a face and even a location. So good to see you all. And this is where you're going to be asking your questions today. Now, we do have a slide presentation. We also are going to be doing some poll questions. So when you answer a poll question, your answer will be anonymous. So no one's going to know who answered what, but we are going to do a couple of those. And then at the end, there's actually going to be a sort of a little evaluation that will be hidden from everybody. So no one's going to see it. We're not going to show the results of that. We will show the results of some of the poll questions because I just think it adds to the dialogue, and it also gives Allison just an idea of where folks are coming from. And we like it to be interactive. As we go through the presentation today, also, if there's a question that is relevant, specific to what she's discussing, I will ask that question of her during that time. If it's a more general question, we are going to hold that until the end. So we are leaving time for Q&A. And I'll be kind of watching that chat throughout and trying to keep track of these questions and which ones go with maybe what she's talking about at that point and which ones we're going to hold. So please feel free to join in that discussion. I love seeing where everyone's coming from. So I am very happy to pass this over to Allison and get everyone started. Allison, thanks for joining us. I'm going to kick this over to you.
Okay, great. Thanks. Hi, everybody. I'm Allison Lindauer. I'm from the Oregon Health and Science University here in Portland, Oregon. And I am just delighted to see everybody's video on. It's really dull these days to give a talk to blank screens. And I really hate it when I give a talk and everybody goes off their video. So what a special group. You're all willing to share, and I really appreciate that. I'm hoping too that you will add to the chat box and contribute your questions, because that helps me feel out, kind of what you need and what you want to hear about. So yeah, like Anissa said, I'm a nurse researcher at Oregon Health and Science University. And my allergies are really bad. Happy spring. So if you see me with my tissue to my nose, I apologize. So I'm going to share my screen and we'll get started. All right. So can everybody see the screen? Yeah, great. Thanks, Kelly. So today I want to talk about Parkinson's disease and dementia. As Anissa pointed out, my specialty is in memory care, cognitive care. I see patients who have dementia for all sorts of reasons, for Parkinson's, Lewy body, Alzheimer's, frontotemporal. And the common denominator is there's usually a family member involved. And I'd say 8 to 9 times out of 10, that caregiver is either contributing to the visit in place of or with the person who has the memory trouble. And oftentimes that person is a little bit on the stress side. But the other thing I've noticed over my longer and longer career is that there's beauty in the strain. It brings families closer, opens up new avenues of communication, really gets people to the essence of who they are. And that's why I chose this picture. This is hard, rugged ground. There's nothing easy about getting and navigating around the difficulties that families face, but at the same time, there is beauty to it. So again, I'm at the Latent Aging and Alzheimer's Disease Research Center. We're one of 31 NIH-funded Alzheimer's disease research centers of excellence in the United States and the only one in Oregon. We use the term Alzheimer's, but it's much more inclusive than that. We conduct studies, everything from clinical trials of medications to my work in assessing how we can use telehealth for families to support them, imaging, pathology, all kinds of stuff. It's a fun place to work. We also evaluate and treat people with memory trouble and their family members. And this is our email and our phone. If you have questions, interested in research, whatever, go ahead and give us a ring. So today, I'd like to review the characteristics of dementia and then discuss some of the unique challenges families living with Parkinson's and movement disorders face. And then we'll take a Q&A and we'll chat. So my specialty area is really about caregiving. I'll be honest with you, there's a lot of movement disorders that I know a little bit about, but not a lot. I did work for several years at our Parkinson Center, where the focus of my work was on palliative care. So not diagnosis, but more end of life. So many of you know this. Hope you don't see that. But just to reiterate, Parkinson's disease is one of the many movement disorders that's complex and often difficult to identify, diagnose, and treat. The main ones we see in our memory center are those that are Parkinson's disease and Lewy body, which are very similar. And you can read this, but essentially what we know about the difference between the two is that Lewy body disease comes before the movement symptoms. So the first symptoms are cognitive. And so when our neurologists make a diagnosis, the general guide is if you had memory problems, hallucinations, sleep problems, about a year before tremors, stiffness, that's more likely to be Lewy body. If the tremor, the bradykinesia, and so forth came first before the cognitive problems, that diagnosis is more likely Parkinson's. What we do know is there's a lot of blurring between the two, right? For anybody that comes to our practice seeking a diagnosis, wondering if they have dementia, our team carefully looks at, do they meet the criteria for any dementia? So this could be Parkinson's, could be Lewy body, it could be Alzheimer's. The first one is the impairment needs to interfere with the ability to function at work or at usual activities, represent a decline from the previous level of functioning, and not explained by other things. The impairment has to have two other things noted: difficulty acquiring and remembering new information, poor judgment, difficulty reasoning, visuospatial abilities, and impairment in language, and then also personality, behavior, or comportment. So they have to have this, and then they have to have two of these. So for example, a person with Lewy body may be fairly functional, but because of the symptoms, finds functioning at home or at work very difficult. Their impairment may not necessarily be remembering things, but they may have discrete and clear hallucinations, and they may have trouble handling complex tasks. So that'd be an example of somebody with Lewy body dementia. Somebody with Parkinson's dementia, which comes much later in the disease process, may also have impairment in function or work, and then again may have a disability with acquiring and remembering information and having trouble with behavior or reasoning. And we'll talk about that as we go through. I just want to explain a little bit of the difference between Alzheimer's disease and Parkinson's and Lewy body type disease disabilities. Alzheimer's disease is like a ball rolling down a hill. It's a fairly constant hill. It may have some bumps, it may not be perfectly smooth, but that ball goes at the same pace and it just rolls down the hill. And what's so frustrating and difficult for families is the darn ball just keeps going. And we try to slow it down, but it's very hard. Families living with Lewy body notice that the ball bounces. And the bouncing part is these, what we call that fluctuations in attentiveness, concentration, memory. Some people will have fluctuations during the day. Some people may have fluctuations during the week. And so but it is more of a bouncing ball. So for example, in the morning, some people will be just really their normal selves, but in the afternoon, just kind of not engaged. And it's a funny disengagement that's very baffling to families. Some of these features are noted. The other thing we have with Lewy body disease is well-formed hallucinations. So people who see little animals, little people, there could be other reasons for those hallucinations, but if they come to us with concerns about their memory or their judgment, or the family does, and they talk about these hallucinations, that's a huge red flag for us. The hallucinations typically are not frightening. Sorry. So for example, one of my colleagues took care of a person whose hallucination was a dog he had in his younger life is at his side, which is lovely, and we're not going to treat that. Sometimes though, especially in the later stages, the hallucinations can get difficult. And we'll talk about that a little later too. People with Lewy body disease tend to have difficulty with attention and focusing. The Parkinson's trajectory is very similar to the Lewy body trajectory in that it's a bouncing ball, but the fluctuations may not be quite as pronounced, and it's much later in the disease process. Oh, I'm sorry, here's the bouncing ball again. And similarly, very similar to what we were talking about earlier, but again, the symptoms, the hallucinations, the cognitive problems can be years after the diagnosis of Parkinson's. Not everybody with Parkinson's gets a dementia, many do. So again, here's just a graphic for you. If the onset of symptoms are early, like cognitive or hallucinations, we think Lewy body. If the memory trouble and judgment occur later in the disease, it's often Parkinson's.
I had a question for you, Allison.
Yeah.
We're talking about the Lewy body and how the waxing and the waning of the cognition comes first, and then some of the PD symptoms. We had a question about non-motor symptoms. So I know we probably are looking at the motor symptoms that might show up at that point, but can you talk, or are there any non-motor symptoms that people would want to look for?
Yeah, the motor symptoms are tricky, aren't they? It requires somebody who's a real expert at teasing out what's going on. But the non-motor symptoms, the GI issues, the mood issues, those may or may not be symptoms of Lewy body. They may go hand in hand. It's difficult to tease out. And I'm sorry, I don't have a real clear-cut answer for you. But I think, in the conversation we would have with somebody, if we're hearing things like a constipation or difficulty with mood and hallucinations, those would concern us. Issues around sleep are, again, a red flag. We hear things like people thrashing around in bed, or a couple that shared a bed but no longer share a bed because the person who has the movement disorder is too restless. Those are things that flag us as perhaps being a Lewy body dementia, and those can occur earlier. And then I think what you're also asking us about is the fluctuations. And that one I'm not entirely sure about, I'll be honest with you.
So just one last kind of add on to that question.
Yeah.
Is there any correlation at all between having higher levels of depression and cognition?
Yeah, that's a great question. Yeah, there seems definitely tends to be a relationship between dementia and depression. It's complicated, I'll be honest with you. Not everybody that lives with depression develops dementia, and not everybody with dementia has depression. However, we do see it as one of the risk factors, and we really encourage people to seek treatment if they're having depressive symptoms, treatment such as therapy or medications. I had another thought back there about depression and dementia. Oh, sometimes depression can look like dementia. So when a person comes into our clinic, we ask them lots of questions about mood. We do screening for their level of depression, because sometimes a person with dementia will be kind of flat. They'll have trouble remembering important information. They may just not want to engage. And that could be depression, it could be grief. And so it's our job to really tease those apart. Should I keep going?
Yes, go right ahead.
Thank you. Let's talk about families. Families, and by families, I mean everybody, right? The person who's dealing with the diagnosis, the family caregiver, kids, parents. These disease processes bring a lot of challenges. Many families get really good at identifying when there are fluctuations, so they know, okay, well, we can't do anything after such and such a time, but sometimes that can get tricky. The hallucinations can be distressing or upsetting to families. There are the mood issues, the mobility, the sleep. So who are the care partners? Who takes care of somebody with a dementia? Now, this is in data from a national study, and this is a more global representation of care partners. My sense is these numbers are a lot higher, but of all the caregivers in the United States, 36 report high emotional stress, 17 report physical strain, 23% have difficulty caring for their own health, and almost 30% of those who live with their person feel alone. So despite the fact that they live alone, they feel alone. I would suspect that families who are living with Parkinson's or Lewy body dementia, that these numbers are higher. Not only do you have the emotional strain, you probably have some of the physical challenges, back pain, knee pain, things that have to do with moving or walking will make life harder. And often families, I say this over and over and over, people who care for somebody else often disregard their own health. They don't want to take the time to make the appointment, to take care of themselves, frankly. Another thing I find really concerning is that of the people that care for somebody with care for an adult, report some type of abuse by the parent they're caring for. So for example, a daughter will be caring for her mother with Alzheimer's, but the mother was abusive towards the daughter as a child. So the relationship is really difficult. So for that, I point this out because when you hear me talk, I don't use the term loved one. Not everybody loves the person they care for. And I just want to lay the cards on the table. So, for those of you that may be in that situation, this requires extra support. You're the kind of person that probably needs a little extra help from your community, a little bit of emotional support, because it's a really tough place to be in. The other thing that happens is that oftentimes, not intentionally, maybe the person with dementia may abuse their care partner. And I think for many care partners, the really hard part is if the person with dementia uses words that are hurtful. They wouldn't have done it as the person they used to be, but with the dementia, that changes them. And then this abuse is often reciprocated. So oftentimes in these situations, this is a situation where we would definitely want some kind of support systems in place. It may be involving the adult protective services so that family can get the support they need. Why do people feel burdened? Why do caregivers feel burdened? Well, we talked about feeling lonely. Oftentimes when you are changing or your family members changing, we see the grief come through. We call it pre-death grief, and it's kind of a constant, things are changing over and over. I often hear things like, this is not the man I married. This is a completely different person, but you know, this is what I signed up for, right? Financial strain, family conflict, uncertain future, and then behavioral symptoms. And that's what we'll talk about. Before we get there though, I want to remind you that caring for somebody with a chronic illness is risky, especially if that illness has to do with cognitive changes. These people are much more vulnerable to depression, pre-death grief, high blood pressure, immune system problems, diabetes, sleep disturbances, memory problems. This is why it's really important that families take care of each other, that the person with the cognitive impairment encourages their family member to get out, to honor them by using daycare services or giving them a break. We know that that can help. So here's your first poll. How are you doing? And I'll just be quiet for a minute. And Kelly, can you tell me when you think we're done?
Sure.
Yeah, it looks like they're still answering.
Okay.
Yeah, about 60%.
Yeah, okay, great, thank you. So this lines up with what we were talking about earlier, right? About 84% of you feel some type of emotional strain, much higher than the national average. I can appreciate that. The physical strain is hard. 45% of you have some type of physical strain. 14% experience some type of financial strain. Along with the national numbers, over 30% of you feel alone or isolated, and many people, at least 19%, feel all of the above symptoms. So thank you for taking the time to talk about that. Okay, so I want to take a minute.
Can I ask a question real quick of you, Allison?
Yeah.
Someone had brought up a really good point, and they said for them, they experience more demoralization than depression. Can you just spend a second on talking about that?
Yeah, I love that word demoralization. I think that's a really great descriptive term. And, you know, I think that the person that wrote the question could probably explain that in more detail. My guess would be you work really, really hard and things still don't improve. It's not like things are getting better. It can be very frustrating and very hard. But let's take a minute and talk about that, because this is an area where you may have some impact. And let's talk about behaviors. And I'm going to kind of speed up a little bit because I'm mindful of the time. But when we have our Q&A session, let me know if you want to go back to some of these. So you'll read in the caregiving literature this concept of behavioral and psychological problems or symptoms of dementia. And by symptoms or behavior, we often talk about, what is the person doing that's distressing? But I also want to point out that when we talk about behaviors, we're talking about ways that we all communicate. All of us use behaviors to communicate. Most of the time, we use words with the behaviors to deliver a clear message. So smiling, clapping, frowning, all behaviors that help us communicate. Happy guy there. We also use behaviors to communicate frustration, anger, fear, grief, sadness. I love this picture because not only, you just know that this person is frustrated. The jaw is clenched, the eyes are clenched, everything's clenched, right? And you'll know without any words that this person is really very frustrated as well, probably a little bit mad. And so you can tell by their behaviors what's going on. So this is something that I work on a lot, and I'd be curious from your polls to find out what goes on in your families to see, should we keep talking about this, or are there other things you'd like to talk about? And again, this applies to the whole family. Whether you have the condition or you care for somebody with a condition, it applies to everybody. Okay. My goodness. Okay, so I'm going to talk this through. It does look like a lot of you deal with some type of behavior, either from, it could be going both ways or not. Almost half of you experience some type of daily behavior. And then others experience it 30% during 2 to 3 times per week, and then about once a month. And some people just never do, which is nice, I think. Oh, this is another poll for you. Sorry, I'm making you work today. I want to know, do you understand what's going on? Do you know how to cope with it? So I understand their behavior and I know what to do.
And while they're answering that question, I did have a clarifying question that just came in. They want to know if the behavior that upsets me but is not abusive, which are we talking about?
Oh, thank you. I'm sorry. One that upsets you. It could be abusive, but it doesn't necessarily have to be. And so, for example, my family member that I live with refuses to brush his teeth in the evening. And I know that he should. I don't want him to get problems with his teeth, but he fights me. That's a behavior that's upsetting, right? It doesn't really matter what the behavior is, it's how you experience it. All right, so about 50% of you know how to cope and about 50% don't. So what that tells me is we can move forward with this talk and maybe give everybody some tips. Okay, so what I'd like to do is talk for a minute about how my work and my teams address behaviors. So we start with the ABCs, and they're a little bit out of order, but bear with me. The very first thing we do is we want to know what is the behavior that is occurring. So let's use the toothbrushing example. A family member may come to me and say, my husband refuses to brush his teeth. Yes, that's a behavior. You're absolutely right. That belongs at the top of the pyramid because we want to know what that behavior is, because if we can't name it, we can't tame it, right? But then I'm going to say, okay, well, tell me what happens before, and then tell me what happens after. And by being a detective, by being a sleuth, you can often find tips or ideas to help you with those behaviors. The example of the toothbrushing is very common, and the solution I have is a little simplistic, so bear with me for those of you who are experienced. So the first thing we want to do is describe the behavior in detail. So he walks into the bathroom, I tell him to brush his teeth, he says no, I tell him again, he keeps saying no, and then he just slams the door, and I know he didn't brush his teeth because his toothbrush is still dry when I go in there, and I just am so worried. So there's a couple layers there, right? So let's stick with the toothbrushing. We can talk about the family members feeling frustrated and worried about behavior too, but for today, due to the short time, let's talk about the toothbrushing. So now we know that the person, let's say this person has Parkinson's dementia in the later stages. The person is told to brush teeth, doesn't want to, he's told again, doesn't want to, slams the door. Then we want to know, well, what's the trigger? What is it that makes them say no, no, no? Well, their family members saying, do this, do this, do this. And they want to maintain their independence. They want to maintain their dignity. They want to maintain control of their lives. They may want to brush their teeth, but they may not want to be told. Hard to know exactly what's going on. And with dementia, sometimes we never know. We just have to make our best guess. And then we also look at the consequences. What happened afterwards? Did he not brush his teeth and everybody just went to bed and everybody's feeling a little frustrated? Or, you know, what happened afterwards? I don't find the C as helpful, frankly, as the B and the A, but oftentimes, every once in a while, we come up with a good clue on the consequence. So that's where we think about the activators, what happened before the behavior, and then what happens after the behavior. So I'm going to take us through a case. This is a case, a family that I worked with. It's all mixed up and jumbled so that they're not recognizable, but it's also a case that I have worked with. So let's say Andrea is Ted's wife, and Ted has Lewy body disease in the more moderate stages. 4 times a week or so, Ted tells Andrea that she needs to cook extra food for their company. Andrea is angry. She knows, because of her experience in her family, that Ted is referring to the little people in his hallucinations, but he doesn't quite put that together. So Ted sees lots and lots of little people around the house. They sit on benches near him. They're not frightening. They're perfectly nice, but they're very clearly little people around the house. And he wants to take care of them. So he tells Andrea, look, we got to make dinner for all these people. And she just feels really frustrated about this. She gets really grumpy. She has a glass of wine or 3 while making dinner. And she wants Ted to just stop asking her to make dinner for the company because there's no company there. So you can see how this is a problem for this family, right? You can see the stress. You heard it in my voice. You can see that both people in the relationship are engaging in behavior. Both people in the relationship are frustrated. So we really need to try to figure out, how can we help Ted and Andrea get to the bottom of this? How can we modify things so that their family issues can change? So we go back to the ABCs. We start with the B, the top of the pyramid. Andrea takes some time to look, listen, and think about Ted's behaviors. She notices what happens prior to the behaviors, and then she notices how she and Ted feel afterwards. She then brainstorms. Now, the brainstorming part I find is much more helpful when you can do this with somebody else, a family member, a close friend, where you just talk about all the ways you possibly could dial down the behaviors. We're not going to cure this, but could we dial it down? So Andrea realizes she too is demonstrating behaviors. She knows she can't control the hallucinations. So she brainstorms with Ted's sister. You get ideas. And so some of the ideas might be Ted's sisters say something like, you know what, Andrea, let's just remove you from this situation twice a week. I'm going to come over and make dinner and you just get out of the house. That would be great. But then Andrea also learns that this technique that we talk about a lot is listen with respect, comfort, and redirect. Ted, I know there are lots of people here. We both know it's your hallucinations. You know what, let's just go watch the Olympics on TV for a little while, because we cannot explain to Ted that the hallucinations aren't going to go away. He probably knows that, but for him, they're real and they're important. So we need to get him turned around, paying attention to something else. Listen with respect, comfort, redirect. So the other thing that I notice with families is they oftentimes will make a plan, but they don't try it, or they'll try it and it doesn't work the first time, and so they give up, they get frustrated. They get, as our person said earlier, demoralized. So know that this process takes time. It's not as simple as I made it out to be. Make a plan, try it. If it doesn't work, come back and try it again. And then call on your resources to help you. Your neurologist, a nurse, a social worker, if you aren't making progress, your support group people. Find people to support you. And then always make time for yourself. It's really important when, when things get stressful to just step back and give yourself some space. It reminds me of when I was raising my children, the need for me to take a timeout. So when I gave my kids a timeout, I needed a timeout. We all just need a break now and then. And so much more information can come to us when we take a break and step back, when we can remove ourselves from the situation, become the scientist, and examine the problem with a clear eye. So I'm just curious, is any of this helpful? I'm going to think about making an ABC plan to help me and my family cope with our behaviors. Nope, not going to do it. I don't have time. Yeah, maybe. I think so. Likely. Sure, why not? Got nothing to lose. It's cheap.
And while they're answering that poll question, Allison,
Yeah.
we had a comment question that this person said, I found that my husband accepts it from me when I tell him that the little people are part of his imagination. Is this acceptance atypical? Is this something that people can do?
That's a great question. So I think the question is the person who's having the hallucination accepts the point that it's part of his imagination? Okay, everybody's different. I mean, we all, some people won't, some people will. And I think it's just marvelous that that person does accept that as part of his imagination. Others may not. And that's, sometimes we have to tell what a colleague of mine says is a heart or a love story. I'm telling you the story from my heart. It may not be the complete truth, but it helps us move forward. I know you see the little people, and I think the little people are important, but I can't help them today. Something that just reassures. So this is great. You're a great group. You're so engaged. You're so willing to try things. I'm really impressed. Maybe, I think so. Only about 3% of you just like, nah, this isn't for me, and that's perfectly fine. And sure, 16%, like, why not? Got nothing to lose, right? And so this is where I come to my shameful, what's it called, promotion. I have funding from the National Institute on Aging, and we do this work with families. So if you live in Oregon, Washington, Kentucky, or Georgia, that's where Alzheimer's disease research sites are. So I teamed up with those sites. And you want to do this some more, give us a call. We'd be happy to chat with you, see if it's a good fit for you. In this study, we take time to really break down the issues. We introduce you to other people living in your situation. We ask you to complete surveys. And for people who've done the whole shebang, they get $100. So I'm going to leave this on the slide set for you to look at later, but just know it's available to you if your family member lives with dementia. So just to review, we talked a little bit about Parkinson's and Lewy body. We talked about the effect of caregiving, and we talked about some strategies to address burden. And this is a question that I am not going to see the results of right now. I did ask the team to collect this data so I have to take this down, so I can make sure that future presentations are helpful to you. And then later on, I'll just see what you had to say and I'll take your feedback. I think feedback is so important to me. And I'll just leave that one up. I can't see it. So I want to thank you for your time. I know all of you have very busy lives, and you've carved out this time, and I thank you for it. If you have questions, comments, feel free to contact us. This is our phone number. And then anybody who's interested in research, we ask them to contact at adresearch@ohsu.edu. And I believe that's all I have. Yes. So now I would love to hear your questions.
All right, we have quite a few. All right, I'm trying to pull some of these that are just coming off in here. So I try to sort of put these in categories to make sense, but I did have an earlier question that, since you were describing different types of dementias, if you could explain the term of what vascular dementia is and how it's different from Parkinson's disease or Lewy body dementia.
Yeah, that's a great question. So think of the term of dementia as an umbrella term. And under it, we have different types of dementia. So to make it, to use a relevant example, we have COVID, the COVID disease, and then we have different types of COVID, right? We have the Delta and the Omicron, they're subtypes. So vascular dementia is a subtype of dementia, and it occurs when the circulation to the brain is impaired, kind of like hardening of the arteries with the heart. It's the same thing, hardening of the arteries in the brain. The brain doesn't get the blood it needs. Those parts of the brain gradually die, and then it affects a person's thinking. Anissa, I see a question here. If it's okay with you, I'd love to answer. How do we, let's see, sorry, it was, what should we not say about the hallucinations? I think that's a really respectful question. And every family, again, is different, and you kind of have to feel around what works for you. The first message I'll give you is whatever works for you is fine. If it's one of those heart stories where you're just kind of brushing them off, maybe not giving them the full truth, and that works, that's all right. What we're all aiming for is for the family as a whole to feel comfortable and safe. So whatever you need to do that. So in one family, we tell the person, oh, it's your imagination, it's the Lewy body playing tricks on your brain, you're fine, you're safe, I love you, perfect. For another family, there may be the hallucination, and this had happened with me, that the people next door are having a party and they didn't invite me, and I'm really, really hurt. That's a difficult hallucination because we don't want our person feeling hurt all the time. So you may close the blinds and say, oh no, that they're not having a party, and they probably aren't, right? But you could say, those people, we don't even know them. Don't worry about it. It doesn't have anything to do with us. Let's go watch some TV. It's perfectly okay to distract. Again, go towards what makes the family as a whole feel better. The other hallucination that I have heard of is seeing people that have passed away. I saw my husband. The family knows that the husband has died 10 years ago, but it's very hurtful to tell that person, no. He died years ago. He's gone. because dementia affects how we think, that kind of response can be very upsetting. So you can say things that as the smoother edge of the truth. I see you're seeing him again. I'm sure he loves you. You'll see him again soon. You'll see him at some point. I'm sure he's thinking of you. Those kinds of things. And then again, redirect. Let's go look at the tulips that are blooming. Did you see that my tulips are blooming? They're beautiful. Let's go. Okay, Anissa, I'll turn it over to you.
No, that's okay. This is fantastic. So we've had several questions about strategy. So, you know, you've talked about redirection. Should we say, I don't see what you see, but it sounds like you said that. One person said, some people feel like they need to convince them that what they're seeing isn't real, that they're hallucinations, but that can go downhill. So is it just finding how to redirect them, kind of soothe them? And is there a way to respond to their person that has this experience, that their frustration, to kind of reduce their anxiety as well as their own, the care partners?
Sure. Yeah, no, those are great questions. And again, I think that the fact of the matter is that all of you that are here today are really the experts in your family. You know what your family needs. You know what works. And so what I'll tell you is what I've seen in my own work, but again, remember you're experts too. Do what makes the family happier. So in many cases, convincing them that they're not real. I don't know why you keep saying that. They're not here. I don't see them. Mary doesn't see them. They're not here. You know, how successful is that? If it's successful and it works, great. Most of the time, though, it's not. I think it helps a little bit to just take it in stride. Oh, yeah, I know you see 50 people in the room. I know. Isn't that interesting? Yeah. Do they bother you? No. Okay, well, let's go do something else. There was a second part to your question. What to say, and then
yeah, to help deflate the
thank you.
That has that their behaviors cause them to have anxiety, then they get anxious and agitated.
Sure. Yeah. And it's again, it's two people, right? I think, you know, it affects everybody. So the sooner you can get the person out of that rut of where they are with the hallucinations, with the distraction, then you get to take a little bit of a break. This is where brainstorming with friends and family can be really, really helpful. What is it that helps that person get their brain out of that rut? It could be, let's have a piece of chocolate. It could be, let's watch TV. It could be that your friends know your situation and they mail cards to your family every week. And hey, a card just came in the mail. Let's open this card and see who it's from. Everybody has something different. One family that I worked with, they went outside and sat in the backyard for 5 minutes, and that helped everybody. In some situations, attending to and dealing with the hallucinations is very, very difficult. And you might even need to talk to your neurologist about medications that can dial down the hallucinations. Whatever you do, whatever strategy you use, or even if you use them all, yeah, and this is absolutely right. This is very stressful. So you need to carve out in your life time for yourself so that you can get a break, so you can let your brain rest. Nobody wants you to be doing this 24/7. It's not good for you. It's not good for your family member. So call on your neighbors, call your church if you go to a church and say, hey, can one of the parishioners take Mary for a drive once a week? Call your local caregiver support program. The National Area Agency on Aging has caregiver support programs all throughout the nation. That's a good way to get the support you need. Think about maybe having your person go to a daycare program. And this is also where families whose person with dementia can be so helpful. You know, if you have some cognitive trouble, if you have dementia, if you have Lewy body, You may not want to have a stranger come in and take care of you. You may not want to go to a day program. But if you think about it as a way of taking care of your family member, and that can be very powerful. You're the person doing the caregiving now by going someplace or letting other people come in.
And I think that goes along with a question that came in just a minute ago about their loved one expects them to be everything and gets frustrated with them if they actually have support coming in, that they don't want it. So what would you say would be a way to handle that? Because that's where the strain comes for the care partner, because they're trying to take care of themselves and get the additional support. And then there's that guilt and stress over their loved one not accepting it. And you're very torn.
Yeah, that's a hard one. So, and again, this is where you have to put yourself at the top of the list. If you're going to be doing this for the quote unquote long haul, you need to preserve your health. And so you must find ways to get breaks. My first piece of advice is don't ask. Don't say, hey, Mary, do you mind if we bring a caregiver in a couple of times a week so I can get out of the house? Don't ask. It's not a negotiable, right? If you want to ask, make it so it's something you can negotiate. Would you mind, could we have a caregiver come in 5 days a week or 4 days a week, right? Because for all of us, our home is really a precious place. It's a safe place. We don't feel comfortable with others coming in. We don't want to go to a daycare. And when our thinking isn't as clear as it used to be, the easiest word to say is no. No, I don't want that. I can't do that. I can't deal. That's just not, so you take it off the table. The second thing is recognize that it'll take between 4 weeks and a month of trying a care partner or caregiver, a formal caregiver, for things to settle down. So the first time you bring a new person into the home to provide care, make it really easy for everybody. It might be really stressful for you. So maybe walk away from the house, walk around the block, but be available on your cell phone in case the caregiver needs help. Or you can tell your family member, listen, I'm just going to go in our bedroom and read for a couple minutes while this person works with you. And over time, it'll get easier and easier, but it can take about a month for everybody to get really comfortable with the situation. And then I would say about 60% of the time, if we can get a consistent caregiver, which I realize is really difficult these days, that person really becomes an essential part of the family.
So someone had written in earlier, if there are behaviors that you can't get them to do, like not peeing on the floor, refusing to take their medications when they're necessary.
Yeah.
How do you overcome some of these counterproductive behaviors?
And this is where somebody like an occupational therapist could be really helpful to you. So you might ask your primary care provider, your neurologist, to make a referral for you for occupational therapy and ask that visit occur in the home. Occupational therapists tend to be really good at problem solving. So for example, if your family member goes into the bathroom and pees on the floor instead of in the toilet, an occupational therapist may say something like, replace the white toilet seat with a black toilet seat, because with dementia, it affects our vision and it's much easier to have that contrast. Or, mint toothpaste can be a little bit hard. Maybe they no longer like to taste. Try bubblegum flavor, try strawberry flavor. And then also with regard to taking meds, have a heart-to-heart with your clinician about what meds need to be taken when, and do we have to take all of these meds? So for example, hopefully there's a time of day when the family member is more willing to take meds. If we can get most of those meds at that time, and then the rest at the time when it's difficult, or just stop the ones that we really, really, really don't need. So those are just some of the tricks I have. But again, an occupational therapist can often be really helpful. And for those of you who live with Parkinson's or Lewy body, you also know that a physical therapist is a really important person on your team, right? Physical therapists not only help you stay strong, but they can look around your house and help you devise strategies to help keep you safe.
I want to go back to the comment earlier about the situations with abuse, whether it was a previously abusive relationship, which is really an added stressor for people, but really for those who maybe have new behaviors and they become violent. And you mentioned about calling adult protective services, and someone wanted to know if there's another way of managing that. And I will say that, and someone did put in the chat that adult protective services isn't there to, like children's services or whatever your state calls it, you know, to come in and take the kids out of the home. It's not there to penalize, but actually they can provide support services and expedite services that can come in and provide some assistance. But above that, is there some additional things that can help people in terms of, you've mentioned an OT and a PT, but are there some other services or supports that you would suggest in those particular kind of circumstances besides APS?
Yeah. So again, I think you've really answered this beautifully. Adult protective services, in my experience, kind of varies a little from state to state, but you know, I think they need to change their name to advocacy protective services or something, because it's also terrifying. But most of the time when I call adult protective services, the families I work with say thank you, because finally somebody has noticed that things are really bad here. But definitely talk to your neurologist about this. We need to know if this is going on, because it could be that the Parkinson's or the Lewy body is getting worse. I mean, this is very simplistic, but maybe there's a bladder infection, or maybe there's a upset stomach, or maybe we just need to change medication so that what's going on, you know, for example, we may need to give a person an antipsychotic, or we may need to give them an anti-anxiety medicine or an antidepressant. Sometimes in these situations, medications are really the only options. But once we can get those behaviors under control, then we can step back a little and see how else we can help the family. But adult protective services is an option. Most people that work with a neurologist or a primary care provider have a social worker that they know of. Try to get in touch with that social worker, because that's the person that's going to help you to identify resources in your community.
And I know we're running out of time, but I would like to end it with some comments. I know somebody said understanding what's going on and coping are two totally different things, which is
So true.
Some
So true.
don't really know how to cope. And somebody else wanted to know, are there any literature or resources to help people find some solace? So do you have like some last minute parting comments about ways for coping for the stress and where they might be able to find some things, some resources to provide some solace?
Yeah, great question. What I've learned over the years is families do well if they can get in some type of support group. So the Parkinson's Foundation will probably have links for you. Your state Parkinson's organization will have links for you. If it's Lewy body you're dealing with, families have told me that they found the Lewy Body Dementia Association really helpful. And knowledge is power, right? So one of the things that the Lewy Body Dementia Association does is they offer classes, which can be really helpful. But I would try to get into a support group that aligns with what you need. So many of you, Alzheimer's Association isn't going to be a good fit, but the Lewy Body Dementia Association probably has a support group in your area, or the Parkinson's Foundation. So I think knowing you're not alone, and knowing that other people are struggling just as much as you are, and giving yourself an hour off now and then is probably the more potent thing you can do. Also, tell your clinician that you are caring for somebody with this problem, because that clinician needs to be watching for things like depression, high blood pressure, vulnerability to getting sick. Your own primary care provider needs to know that you're doing this very stressful thing.
And I will point out that Kelly posted, we do have a online community support group for care partners and adult children on Thursdays. We also have a once a month Real Talk caregiver social work facilitated group. And if you go on our website, we have a list of all over the United States, different support groups, which ones are care partners that are online, that are in person, that are those
Perfect.
that are. So you can go to our website and check those out. And I know that we have support group leaders even on this call today, and they would be listed. So there are lots of resources out there. And I would second that having a support system and that support group is one of the best ways of getting that help and understanding and camaraderie and some walking a similar path. So I want to thank you so much, Allison, for your presentation today. And I know that we just put some links in that chat. And so for those of you who want to be able to refer to those again, just go over to your chat box. And there's 3 little dots. And if you pop that open, you can save your chat. That way you'll have the links for future reference. And we do have a tradition, Allison, as we thank our speakers that come and donate their time and their expertise and helping us to better understand what we're dealing with. It's our wave of gratitude. And I want to invite all of our listeners today to give you that big wave.
Oh, thank you. You're a great audience.
Much.
Thank you. Thank you. Oh, and the heart too. I'm not very good at that.
And of course, heart and thanks to all of you for joining in. And we will see you again soon. Thank you, Allison.
A pleasure. Bye-bye.
Here, bye-bye.